Good morning everyone. I am Dr. IIS VARMA. Today I will be leading the discussion club with the continuation of section 6 of our reading club based on Misch Contemporary Implant Dentistry, which is being conducted in conjunction with International Implant Summit 2026. Today we will begin with chapter 29, Maxillary Anterior Implant Placement. Contrary to missing a posterior tooth, most patients have an emotional response regarding a maxillary anterior missing tooth. Because the premaxillary teeth are directly within the smile line, no question exists regarding the need to replace the tooth, and financial considerations are usually less important. When posterior teeth are extracted, little resistance to the preparation of adjacent teeth may be given to the dentist. Anatomic challenges: natural tooth size versus implant diameter. When an implant is being restored, the challenges are even greater. When comparing the size and shape of an implant versus natural tooth, the implant is often 5 mm or less in diameter and round in cross-section. A natural maxillary anterior crown cervix region is approximately 4.5 to 7 mm in mesiodistal cross-section and is never completely round. In fact, the natural central incisor and canine teeth are often larger in their faciopalatal dimension at the CEJ than in the mesiodistal dimension. Figure 29.15 depicts bone resorption in the maxillary anterior. A. Before the loss of a maxillary anterior tooth, the bone around the roots most often is present. B. Extraction often causes a loss of the thin labial plate of bone over the root. After extraction, the residual ridge most often is decreased in width. C. After 6 months to 1 year, the residual ridge continues to resorb and becomes division BW. D. Eventually, the residual ridge forms a CW bone volume that is slightly deficient in height and less than 2.5 mm in width. E. This bone volume often extends almost to the floor of the nose. Box 29.1 shows ideal average implant diameter. Central incisor 4 to 5.2 mm, lateral incisor 3 to 3.5 mm, canine 3.7 to 4.2 mm. Implant position: the mid-faciopalatal position of the implant is in the middle to slightly palatal 0.5 mm of the edentulous ridge of adequate contour. This approach permits the use of the greatest diameter implant. The crustal bone should be at least 1.5 to 2 mm wider on the facial aspect of the implant and 1 mm on the palatal aspect. Therefore, for a 4 mm diameter implant, a minimum 6.5 mm faciopalatal width of bone is required for the central or canine position, and 6 mm of bone width is required for a lateral incisor with a 3.5 mm implant. Facial implant body angulation. However, the crown of a natural tooth has two planes, and its incisor edge is parallel to the facial emergence of the natural tooth by 12 to 15 degrees. Therefore, when the implant is angled to the facial emergence of a tooth, an angled abutment of 15 degrees must be used to bring the incisor edge more parallel. Soft tissue incision surgical protocol. Several different approaches have been advocated to enhance the soft tissue appearance. The approaches may be surgical, addition or subtraction, or prosthetic, and include: 1. A soft tissue graft before bone augmentation. 2. A soft tissue augmentation in conjunction with a bone graft before implant insertion. 3. Soft tissue augmentation in conjunction with implant insertion. 4. Soft tissue manipulation at the implant uncovery procedure. 5. A prosthetic modification of interproximal contact position. 6. Creeping attachment around the implant crown. Or 7. A prosthetic replacement of the soft tissue with pink colored porcelain. Box 29.2 shows soft tissue contouring and emergence profile. First, pre-prosthetic surgery. Soft tissue graft before bone augmentation. Soft tissue graft in conjunction with bone graft before implant surgery. Second, surgery stage 1. Soft tissue augmentation, non-resorbable hydroxyapatite graft, lingually oriented incision to position more tissue to the facial, papilla saving incision. And third, surgery stage 2. Connective tissue graft, subepithelial, soft tissue plastic surgery, gingivoplasty, coarse diamond, prosthetics, wide healing abutment, temporary contouring through provisional restoration, anatomic abutment, tooth colored abutment, pink porcelain or zirconia on abutment, lingually oriented incision to position more tissue to the facial. Complications. The primary aesthetic complications of maxillary anterior single tooth implants include interdental papillae, deficiency, and gingival shrinkage after crown delivery. Interdental papilla deficiency. The interproximal CEJ of a natural tooth exhibits a reverse scallop towards the incisor edge. The same pattern is followed by the alveolar interproximal bone, which is more coronal in the interproximal regions than in the facial or lingual plates. As a consequence, the probing depth in the papilla region of a natural tooth is quite similar to the facial or palatal probing depths. Interproximal bone around an implant does not follow such a contour. As a result, the interdental papillae, which look natural and rise to fill the interproximal regions between healthy and decent teeth, exhibit greater probing depths than the other surfaces of the implant crown. In fact, because the interproximal bone height also may be lost next to the adjacent teeth, the dental and implant papilla also correspond to greater proximal probing depth next to the natural tooth. A greater sulcus depth increases the risk of shrinkage after gingivoplasty or later even with good daily hygiene care. As a result, even years later, the tissue may shrink and result in a poor interproximal aesthetic situation. Figure 29.31 shows most common aesthetic complication in the premaxilla is the inadequate soft tissue drape around an implant crown. The patient's left central incisor exhibits black interproximal spaces. Nasopalatine, incisive foramen and canal anatomy. The nasopalatine incisive canal connects the oral cavity, that is nasopalatine foramen, with the floor of the nasal cavity. The soft tissue overlying the foramen is often associated with two lateral canals, which often fuse before exiting the foramen. The nasopalatine foramen is located approximately 7.4 mm from the labial surface of an unresorbed maxillary anterior ridge, and that the distance will vary after the amount of osseous resorption after extractions. The mean diameter of the nasopalatine foramen was shown to be approximately 4.6 mm, that is ranging from 1.5 to 9.2 mm. The length of the nasopalatine canal has been reported to be approximately 9 mm with a range of 3 to 14 mm. The average height has been documented to be approximately 10.08 to 10.86 mm. However, as the premaxilla resorbs, the nasopalatine canal decreases in size. Surgical approaches to the nasopalatine canal. In most cases, an implant may be positioned to replace a central incisor without encroaching on the nasopalatine canal. However, if extensive resorption or a large canal is present, then the nasopalatine canal may have a direct effect on the implant positioning. Therefore, ideally, the implant should never contact any soft tissue contents of the canal. To avoid this from occurring, there exist several approaches when the nasopalatine directly affects the implant positioning. Croat et al. Reported that approximately 4% of the nasopalatine canals directly affect the ideal positioning of implants in the premaxilla. Bone grafting the nasopalatine canals with delayed implant placement. One option when the size and position of the nasopalatine canals impinges on the implant placement is to enucleate and bone graft the canal. The nasopalatine canal is exposed by full thickness reflection and the soft tissues within the canal are entirely curated. Serrated spoon excavators, example Lucas 86, may be used along with a round carbide burr to completely remove any soft tissue remnants from the canal. Rosenquist and colleagues first reported on removing the contents of the nasopalatine canal and autogenous bone grafting the area. Implant placement was delayed for approximately 5 months with 100% success. Since then, numerous additional studies have shown positive outcomes with this procedure, including guided bone regeneration techniques along with grafting the nasopalatine canal. Removal of the canal contents plus implant placement. A second option includes the enucleation of the nasopalatine canal followed by immediate implant placement. The incisive foramen is first reflected and identified, and a periodontal probe evaluates the angle and depth of the bony canal to ensure a minimum length of 9 mm. The soft tissues in the incisive canal are curated from the canal side, which is approximately 4 mm in diameter at its apex. A round carbide burr, example number 6 or number 8 round burr in a straight handpiece may be used to remove the soft tissue remnants. In addition, the trauma from the round burr initiates the regional acceleratory phenomenon RAP, which allows for more predictable healing. Once the soft tissue is removed, drills progressively increase the diameter to the final implant osteotomy diameter 2 mm below the final height of the canal. A blunt osteotome and gentle, sudden impact force with a mallet then prepares the apical 2 mm of the implant site. A large diameter threaded implant greater than 5 mm is generally used and should be greater than the diameter of the foramen. When the foramen diameter is greater than that of the implant available, the canal is augmented with an autologous or allograft bone graft and the implant insertion is delayed for several months. This technique is often clinically challenging. Positioning the implant away from the nasopalatine canal. The most common position would be in the embrasure area of the central and lateral position. This would result in maintaining the anteroposterior spread along with not penetrating into the canal. However, care should be exercised not to angulate the implant too far to the facial, as this may impinge on the aesthetics of the process. Kraut and colleagues evaluated CBCT scans and found that 4% of the time the nasopalatine canal would interfere with the normal preparation of an osteotomy for an implant. Neurosensory impairment. A third complication of an nasopalatine foramen implant is associated with enucleation of the soft tissue from the foramen, which may result in neurologic impairment of the soft tissues in the anterior palate. These complications may be anesthesia or paresthesia to the soft tissue or dysesthesia, resulting in a burning sensation, which have been reported in numerous reports. In most cases, collateral innervation from the greater palatine nerve to the anterior palate is present, which eliminates any possible neurosensory disturbances. Implants and approximation to the nasal cavity. Anatomic considerations. The anterior nasal spine has an anterior component that averages 4.1 mm, ranging from 0 to 9 mm in adults. Posterior and lateral to it, two flat processes, the ala of the premaxilla, project superiorly and laterally. The pyriform aperture is bounded below and laterally by the maxilla. The breadth of the pyriform aperture in adults ranges from 20 to 28 mm and averages 23.6 mm. Moving on to chapter 30, Mandibular anatomic implications for dental implant surgery. Mandibular anterior, hourglass anterior mandibles. The mandibular anterior region has historically been considered one of the safest and most predictable regions for implant placement. The predictability stems from the favorable quality of bone, that is, thick cortical and dense trabecular bone, most commonly present in this area. The morphology of the mandibular anterior has been classified as the following shapes: hourglass, ovoid, pear, sickle, and triangular. The pear shape, which is usually abundant with the bone, has been shown to be the most common among edentulous and dentate patients. Figure 30.3 depicts anterior mandible cross-sectional morphology and treatment. A. Pear shape, B. Sickle shape, C. Ovoid, D. Triangular, E. Buccal constriction, F. Lingual constriction, and G. Hourglass. Lack of keratinized tissue. As the mandibular osseous process progresses, the presence of keratinized tissue becomes more compromised. In general, implants are healthiest when there exists sufficient keratinized tissue. Some reports indicate the lack of keratinized tissue may contribute to implant failure. Mobile, non-keratinized mucosa has been shown to exhibit greater probing depths, which has been confirmed histologically. The absence of keratinized mucosa also increases the susceptibility of peri-implant regions to plaque-induced destruction. Additional studies have shown that mobile mucosa may disrupt the implant epithelial attachment zone and contribute to an increased risk for inflammation from plaque. Inadequate width of bone. A common consequence of tooth loss and bone remodeling in the mandibular anterior region is the resultant narrowing and knife-edge configuration of the mandibular bony ridges, that is division B available bone. Clinical relevance. Therefore, before implant placement, it is often necessary to reduce the bone width, that is osteoplasty, which results in an increased horizontal width of available bone. Mandibular posterior. Lack of bone height. Vertical bone augmentation, that is with simultaneous or delayed implant placement. Increasing bone height in the posterior mandible is one of the most challenging procedures in implant dentistry. To increase the available bone, various techniques including autogenous block grafts, guided bone regeneration and distraction osteogenesis have been discussed in the literature. However, an increased rate of surgical complication and enhanced patient morbidity have been associated with these type of procedures. Shorter implants. Recently, the use of short implants, approximately 8 mm in the atrophic posterior mandible, has been introduced to circumvent the need for vertical bone augmentation. Bony anatomic areas. Posterior lingual undercut. In the posterior mandible, it is imperative the implant clinician have detailed knowledge of the three-dimensional anatomy of the area. A lingual undercut is often present, which may lead to complications with life-threatening consequences. Pernia et al. Classified posterior lingual concavities into 3 types. Type 1, 20%, flat depressions less than 2 mm in depth. Type 2, 52%, occur with 2 to 3 mm in depth. Type 3, 28%, showed significant concavities of more than 3 mm. Clinical relevance. If perforation of the lingual plate is made with either the surgical drill or implant placement, life-threatening situations may result from sublingual bleeding. Within the lingual undercut, the sublingual and submandibular arteries are present. Trauma to either of these arteries can result in a sublingual hematoma and airway compromise. Vascular considerations. Incisive canal vessels. The incisive artery is the second terminal branch of the inferior alveolar artery, which is a branch of the maxillary artery. The incisal branch continues anteriorly after supplying the mandibular first molar area, where it innervates the incisal teeth and anastomosis with the contralateral incisal artery. In rare cases, the incisive canal is large, lending to greater bleeding during osteotomy preparation or bone grafting procedures. The exact location of the incisive canal is easily determined via a CBCT evaluation in the panoramic or sagittal views. Inferior alveolar artery. Clinical relevance. Normally, the inferior alveolar artery is located superiorly to the inferior alveolar nerve within the body mandibular canal. Drilling or placing an implant into the inferior alveolar canal may predispose to significant bleeding. Neural considerations. Lingual nerve. Clinical relevance. When elevating tissue in the posterior mandible, always maintain the retractor on the bone and minimize stretching of tissues on the lingual aspect of the mandible. The lingual nerve is very susceptible to neuropraxia types of nerve impairments. In addition, no lingual vertical release incisions should be used because of the variant lingual nerve anatomy. Inferior alveolar nerve. Prevention of iatrogenic injuries to the third division of the trigeminal nerve is paramount in implant dentistry today. A resultant neurosensory impairment in the head and neck region may affect the patient's quality of life and may present potentially significant medico-legal problems for the clinician. To prevent damage to these vital nerve structures, it is imperative for the implant dentist to have a comprehensive radiographic survey of the region, thorough knowledge of the normal versus variant anatomy, and awareness of intraoperative surgical techniques to minimize the possibility of nerve impairment. Basically, the surgical guide is the conduit for transferring the interactive treatment plan from the computer to the patient's actual surgical procedure. This allows the implant dentist to be able to place the implants in the exact location as per the treatment plan. Neurosensory impairment issues are more frequently an inadvertent sequelae of improper diagnosis, treatment planning, or surgical technique. Many of these complications can be overcome by using 3D surgical guides for the ideal positioning and placement of implants. Surgical guides are categorized based on method of retainment, tooth, bone or mucosa supported. In addition, guides are distinguished by the surgical technique involved. First, fully guided. All osteotomies and implant placement is completed through the guide. Second, universal guide. All osteotomies except for the final drill and implant placement are completed through the guide. And third, pilot. Only the first or initial drills is used through the guide. Guided surgery with surgical templates has been reported to improve the accuracy of implant placement in clinical situations in comparison with conventional surgical methods. Nick et al. Showed that implants placed with surgical templates are within 0.9 mm of the planned positions, whereas freehand placement resulted in deviations of approximately 2 to 3 mm. Mental foramen, visualization of mental foramen, two-dimensional radiographs. Studies have shown that in more than 50% of periapical and panoramic radiographs, the mental foramen is not in the location depicted on the 2D image. Conventional 2D radiography should never be used as a sole diagnostic modality in evaluating the foramen position. Three-dimensional radiography. The literature has shown that 3D imaging is the most accurate diagnostic tool to ascertain the exact location of the mental foramen. CBCT panoramic and cross-sectional images together with 3D images are the easiest and most accurate techniques in determining the exact foramen location. Palpation. In rare cases, the clinician may be able to palpate the location of the mental foramen. Most notably, when bone resorption has caused the nerve to be exposed on the residual ridge, the concavity formed by the exposure of the nerve can be determined. In these cases, the location of the mental foramen may be marked with a surgical pen. When the nerve is located on the buccal surface of the mandible, the palpation method of identification has very low utility. Three-dimensional ultrasound. The most promising image technique for the future is ultrasound. Ultrasound has the advantage of no ionizing radiation and the ability to reconstruct 3D images of bone surface to within an accuracy level of 24 micrometer. At this time, ultrasound units are not available specifically for dental use. Surgical principles to decrease neurosensory complications. Safety zone. A 2 mm safety zone with osteotomy preparation and final implant placement is paramount in preventing neurosensory impairments. Therefore, the final implant position should always maintain a minimum distance of 2 mm from the inferior alveolar nerve canal. Compression-related injuries, neuropraxia can occur by encroaching on the inferior alveolar nerve without actual contact. Nerve impairments have been reported when implants are placed less than 2 mm from the canal without actual invasion of the canal. Do not place bone graft material in close approximation to nerve. After tooth extractions, especially in the mandibular premolar areas, care should be exercised in placing bone graft material, autologous, allogenic, xenogenic, in direct contact with an exposed inferior alveolar nerve. Whether socket grafting or in conjunction with implant placement, case studies have shown resultant neurosensory impairment from bone graft material causing compression, crushing or chemical burn injuries. Infiltration technique. An alternative technique in placing implants in the posterior mandible is not using mandibular nerve block anesthesia. Instead, infiltration is accomplished in the soft tissue surrounding the osteotomy site, and the patient is asked to alert the implant clinician on the proximity of the drill to the nerve bundle. This alternative technique results in a very high degree of subjectivity concerning patient's responses because of the varying degrees of pain thresholds. Moving on to chapter 31, dental implant complications. Intraoperative complication. Malpositioned initial osteotomy site. In performing the initial osteotomy for a dental implant, in some cases the initial implant position may not be placed in the ideal location. The osteotomy may need to be repositioned to allow for ideal placement. The use of a Lindman burr, that is side-cutting fissure burr, is ideal for the repositioning of an osteotomy because of its side-cutting capabilities. Lindman burrs allow for easy and efficient positional change with minimal trauma to the bone. Prevention. Surgical templates or implant positioning devices for ideal implant positioning should be used to prevent the improper placement of the initial osteotomy. Facial dehiscence after implant placement. Ridges that are compromised, that is division B, C or D, should be modified to obtain a division A bone, example greater than 7 mm width and greater than 10 mm of bone height before osteotomy initiation. This may be accomplished by either osteoplasty or lateral bone augmentation. After implant placement, a minimum of 2 mm of facial bone should be present over the implant or the compromised facial area should be grafted. Treatment. After implant placement, if there exists less than 2 mm of bone on the facial aspect of the ridge, the site may be grafted with autogenous bone ideally. The autogenous bone is most easily obtained from bone fragments gathered from the fluids of the surgical drills during the osteotomy preparation. The consistency of this bone allows for ease of packing and the graft will have less chance of migrating. Ideally, the autogenous bone should be red or white colored as this signifies live viable bone. If the bone fragments are black or brown, the bone should be discarded as it is most likely necrotic. Allograft bone is not the most ideal bone to graft in this area as it tends to migrate easily after placement and is an added expense. Loss of entire buccal plate. If the entire buccal plate is lost or if mobility of the implant exists, the ideal treatment should include removing the implant followed by grafting the site. After sufficient healing occurs, implant placement may be completed. Partial buccal plate still intact. If no mobility of the implant is present and the facial plate is partially intact, the facial area can be grafted, ideally with autogenous bone from the osteotomy site. Example, bone from the surgical drill. Overheating the bone. One of the most common complications that has been associated with early implant failure and bone loss is overheating of the bone during the osteotomy preparation. This is usually the result of osteotomy preparation in dense bone with a non-ideal surgical osteotomy protocol. The Misch osteotomy preparation protocol has been developed to minimize heat generation in D1 and D2 bone density types. Bone tissue has been shown to be very susceptible to thermal related injuries, with studies showing the temperature threshold to be 47 degrees Celsius for tissue survival when drilling is maintained for more than 60 seconds. If heat generation is higher than this limit, then osseointegration is in question because of the resulting necrosis of the surrounding bone cells. In addition, resultant hyperemia, fibrosis, osteocytic degeneration and increased osteoclast activity may occur, which may lead to a necrotic zone around the implant. Implant pressure necrosis. It is suggested that excessive tightening of the implant creates compression forces within the crestal bone around the implant. This may impair the microcirculation and lead to bone resorption. Prevention. First one is torque. The implant should not be tightened into the osteotomy with excessive torque pressure. A torque value of 35 Newton centimeter is considered safe with most threaded implant designs. If excessive pressure is present, the implant should be unscrewed 3 to 4 mm and then reinserted. Second one is crestal bone burr. Placement in D1 and D2 types of bone. To decrease crestal pressure, a crestal bone burr can be used to minimize the stress at the ridge crest. Use of insertion wrench. To decrease the crestal stress, the implant may be inserted with a hand ratchet to depth, then unthreaded 3 to 4 mm and then reinserted to ideal depth. By unscrewing the implant 3 to 4 mm, the bone is given time to creep, which on reinsertion will have less force at the crestal region. Swallowing or aspiration of implant components. Swallow. If the object is swallowed, usually the patient will be asymptomatic. However, depending on the shape and size of the object, it may need to be removed because of the complication of blockage within the gastrointestinal system. Aspiration. The object may be aspirated into the lungs, in which case the patient will usually be symptomatic. The patient will exhibit signs of coughing, wheezing, hoarseness, choking, stridor or cyanosis. The patient will often complain of pain and discomfort. Treatment. When swallowing or aspiration of implant components occur, the clinician must act proactively to avoid complications and medico-legal issues. First, if an instrument is lost in the mouth, the patient should be instructed not to sit straight up because it will ensure the swallowing or aspiration of the instrument. The patient should turn to the side and attempt to cuff the instrument up. If the instrument is lost, symptoms usually will determine whether aspiration into the lungs or swallowing into the stomach has occurred. If the instrument has been swallowed into the stomach, usually the patient will exhibit no symptoms. If the patient has aspirated the instrument, this will most likely be accompanied with coughing, wheezing, pain and cyanosis. This may be life-threatening and should be treated accordingly as a medical emergency. In all swallowing or aspiration situations, the patient should be referred immediately to his or her physician or emergency room for a chest X-ray. If the instrument has been aspirated, it will usually be located in the right bronchus because the right main bronchus has a more acute angle than the left. Rigid bronchoscopy is usually used for the removal of the instrument under general anesthesia. Dental implant periapical lesions. Retrograde periimplantitis. After implant placement and recall examinations, case reports have shown the genesis of periapical lesions, radiolucency, which may suggest a possible precursor to failure of the endoosseous implant. These periapical lesions have been termed apical periimplantitis and retrograde periimplantitis. The lesions have been defined as symptomatic or asymptomatic periapical radiolucency developing after implant placement with a normal coronal bone to implant interface. Prevention. Prevention of periapical lesions include the following. First, clear evaluation of adjacent tooth structure to rule out pre-existing infection or pathology. Second, pulp testing of adjacent teeth. Third, caution when placing immediate implants into sites with possible pathology. 4. Extensive debridement of pathologic tissue and decortication of immediate extraction sites. Titanium allergy or hypersensitivity. Hypersensitivity to titanium is an ever increasing reportable complication in medicine today that has been associated with a wide range of situations. In orthopedic medicine, there are many case reports of titanium alloy hypersensitivity. Witt and Swan reported 13 cases of failed total hip prosthesis and concluded that tissue reaction in response to metal wear debris may have been the causative factor of the failed implants. This process has been termed repassivation and may produce an oxide that surrounds and turns the peri-implant tissues black. In the dental literature, allergic reactions to pure titanium are rare. However, many authors have suggested there is a higher incidence of titanium alloy allergy with respect to dental implants. It is most likely underreported because of a poor understanding of failure or allergy. Titanium alloy dental implants have been shown to contain many impurities that may trigger type 4 hypersensitivity reactions. Harloff et al. Used spectral analysis to investigate various titanium alloy implants. The results showed that all of the titanium alloy samples contained small amounts of other elements such as beryllium, cobalt, chromium, copper, iron, nickel and palladium. These impurities elements have been shown to be the cause of hypersensitivity reactions. Biomechanical complications. Screw loosening. Abutment screw loosening has been shown to be associated with an approximately 6% of implant prosthesis fabricated. Screw loosening is the most common implant prosthetic complication, accounting for approximately 33% of all post-implant prosthodontic complications. Etiology, external force factors, cantilevers or increased crown height space, parafunction, splinted versus non-splinted crowns, crown or abutment not fully seated, insufficient or excessive torquing, screw diameter, screw material, component fit, implant design. Screw versus cement retained. When evaluating the prosthesis type, cement versus screw, studies have shown screw retained 8.5% had a much higher incidence of screw loosening in comparison with cement retained 3.1%. Screw fracture etiology. The causative factor most likely to induce screw fractures is biomechanical stress to the implant system. The biomechanical stress leads to partially unretained restorations or fatigue, which is directly related to an increased amount of force. Prevention. Immediate treatment of loose screw. Treatment. Explorer removal, ultrasonic or cavitron device, round burr, inverted cone burr, approximately 33.5 burr, slot the top of the screw, manufactured retrieval instruments. Table 31.4 shows neurosensory impairment classification and injury response. First column Sunderland classification, second column Seddon classification, third description, fourth column causes, fifth column responses, and sixth recovery rate. Grade 1 Sunderland classification, neuropraxia in Seddon classification, description, temporary interruption of nerve transmission, conduction block, causes nerve compression, edema, hematoma, minor stretching, thermal, responses, neuritis, paresthesia, recovery rate complete, fast, days to weeks. Grade 2 Sunderland classification, in Seddon classification axonotomesis, description, endoneurium, perineurium and epineurium remain intact. Some axonal degeneration may occur. Causes nerve compression, traction, hematoma, partial crush, edema and stretching. Responses, paresthesia, episodic dysesthesia. Recovery rate complete, slow, weeks. Grade 3 Sunderland classification. There is no Seddon classification. Grade 3. Description, disruption of axon and connective tissue, endoneurium, causing disorganized regeneration. Valerian degeneration occurs. Causes, crush, puncture, severe hematoma, stretching. Responses, paresthesia, dysesthesia. Recovery rate variable, slow, weeks to months. Grade 4 Sunderland classification. There is no Seddon classification for grade 4. Description, damage involves entire fascicle, axonal endoneurium and perineurium changes occur. The epineurium is intact, scar tissue formation. Causes, full crush, extreme stretching, high thermal, direct chemical trauma. Responses, hyposesthesia, dysesthesia, neuroma formation. Recovery rate unlikely. Grade 5 Sunderland classification. Neurotomesis in Seddon classification. Description, complete transaction or tear of the nerve with amputation neuroma forming at injury site. Causes, complete transection and overpreparation with implant drill. Response, anesthesia, intractable pain, neuroma. Recovery rate is none. Fractured implant. Although rare with today's dental implants, fractured implant bodies may cause significant problems for both clinicians and patients. Dental implant fractures may be one of the major causes of late implant failures and may include possible medico-legal issues. Studies by Goodacre et al. Relate the risk for implant body fracture in the early to intermediate period for implants 3.7 mm in diameter to be approximately 1%, the abutment screw fracture risk at 2%, and the prosthetic screw risk at 4%. Fatigue is a more critical factor. Different materials have varying degrees of resistance to repeated loading and subsequent fatigue-related failures. The fatigue strength of titanium alloy is 4 times greater and safer than grade 1 titanium and almost 2 times greater than grade 4 titanium. Long-term fracture of implant bodies and components may be dramatically reduced with the use of titanium alloy rather than any grade of commercially pure titanium. Explanation of dental implants. In some situations, a failing implant or the position of implant necessitates removal with reinsertion in an ideal position. The following are possible reasons why dental implants may need to be removed. Mobility of the implant, extensive bone loss, chronic pain, advanced peri-implantitis, fractured implant, malpositioned implant. Potential complications. Taking an aggressive approach to removing an implant may lead to further bone loss and jeopardize the future site for reimplantation. Because an implant does not contain a periodontal ligament, placing too much force and pressure on it may lead to buccal or lingual plate failure. Loss of bony plates or excessive bone loss may result in the need for extensive bone augmentation in the future. Treatment. Mobile implant. The loss of bone implant integration necessitates immediate removal because infection and further loss of bone may result. In certain cases, the implant may migrate within tissue spaces or may be swallowed or aspirated. Counter torque ratchet. This technique involves placing an abutment or an engaging extraction tool into the implant and reverse torquing the implant counterclockwise. This technique is usually atraumatic. However, caution should be exercised to not use excess force as this may lead to bony plate fracture. Convention extraction techniques. This method uses conventional forceps and elevators and should be used only with minimal luxation to prevent possible fracture to the buccal or lingual plate. After removal, all soft tissue should be removed from the implant site before grafting or reimplantation. A throat pack should be used to minimize the possibility of aspiration of the implant upon removal. Non-mobile implants. A partial or fully integrated implant is usually more problematic and can be in some cases very difficult to remove. Conventional extraction techniques should never be used because they may lead to significant bone loss or fracture. If a final crown and abutment is present, they should be removed to allow for easier access. Counter torque ratchet. This technique involves placing an abutment or an engaging extraction tool into the implant and reverse torquing the implant counterclockwise. This should be used only in poorly dense bone. Care should be exercised in higher density bone because damage or fracture of the implant body or adjacent bone may occur with this type of removal technique. The existing bone density is the most critical factor which affects the ease of implant removal via the counter torque technique. The existing bone density is the most critical factor which affects the ease of implant removal via the counter torque technique. Implant type. In general, an internal hex implant is easier to remove via the counter torque method. External hex implants, because they engage coronal to the implant body, are more difficult to remove because of lack of leverage. Implant thread shape. There are generally 4 types of implant thread designs: buttress, square, V-shaped and reverse buttress. The square thread shape has the highest bone implant contact and will be the most difficult to remove via the counter torque method. Implant body design. A tapered implant design will be easier to remove than a square implant design. The thread depth and surface area decrease in the apical area, which minimizes the torque force necessary for removal. In addition, less chance of fracturing the bony plates exist. Anti-rotational design. Some implant designs contain a vent or opening, usually at the apical end, that will allow for bone growth integration. This will complicate the removal of a partially or fully integrated implant. A trephine or surgical burr technique may be indicated in the removal of these types of implants. Reverse screw techniques. A reverse screw removal drill is usually indicated when the internal aspect of the implant's threads are damaged or when counter torque method is unsuccessful. Caution should be exercised with smaller diameter internal implants, approximately 3 mm, because fracture of the implant body may occur. High speed burrs. The use of a high speed burr is a fast, efficient technique to remove an integrated implant, ideally a tapered surgical burr. Extra long 700 XXL is used to minimize bone removal. The burr is used 360 degrees around the implant to a depth of half to 3/4 the length of the implant to be removed. Copious amount of saline should be used to minimize thermal damage and the possibility of osteomyelitis. This helps to maintain bone and minimize damage to vital structures. After removal, the implant site should be irrigated to remove any particles. Piezosurgical units. A piezosurgical unit uses piezoelectric vibrations to cut bone tissue. By adjusting the ultrasonic frequency of the unit, it is possible to remove hard tissue while leaving soft tissue untouched by the process. Trephine burrs. Trephine burrs are barrel-shaped burrs that are available in various diameters. The burr selected should be slightly larger than the implant crest module because too large of a trephine burr will result in excessive bone removal. Figure 31.68 depicts A. Trephine burrs and B. Removal of implant with trephines. Here we are concluding the session. Thank you for your listening.